In the name of the Father, and of the Son, and of the Holy Spirit, one God, Amen. My beloveds, hello everybody. Today's topic is endocarditis, bacterial endocarditis. So take your pens, papers to make the notes, and I'll try to clarify several misunderstood or confused questions of several previous big exams. And let's go. So the most common causes of bacterial endocarditis tell a story about where the bacteria originated. For native valve endocarditis is a non-drug user in a non-drug user. For native valve endocarditis in a non-drug user, of course, the most likely culprit of Streptococcus is a Streptococcus viridans, a bacteria that lives in the mouth. So think V, verdant, green. Verdant means green. So like plants in your mouth. Yeah, well, for mnemonics. For endocarditis, viridans. For endocarditis relates to intravenous lines, prosthetic valves, iatrogenia phenomena, or intravenous drug use. The king of is Staphylococcus aureus, bacteria that lives on the skin. Okay? So I repeat this for remembering. So for native valve endocarditis in a non-drug user, the most likely culprit is Streptococcus viridans that lives in our mouths, and for endocarditis related to intravenous lines, prosthetic valves, intravenous drug use, catheterization, etc. is Staphylococcus aureus, the bacteria of the skin. So clinical importance, my beloveds, this is the number one most common. What is the most likely? So exam questions. The most common, first most common, I suppose. What is the most likely organism? Question on exams. So if the question mentions a recent, you name it, I don't know, dental procedure and a new heart murmur, the answer is Streptococcus viridans, Strep viridans. If it mentions the intravenous drug user or hospitalized patients with a central line, the answer is Staphylococcus aureus. Don't forget this. Okay? Note, actually about intravenous drug users. In the general population, endocarditis most commonly affects the left-sided heart valves. That is mitral and aortic. However, in people who inject drugs, the most commonly affected valve is tricuspid valves, Leonardo da Vinci valves. Tricuspid valve on the right side of the heart. Yes, Leonardo da Vinci is the first that described tricuspid valve, my beloved, famous painter. So, exam gold, actually in clinical importance. The bacteria from contaminated needles enter the venous system and hit the tricuspid valve first. This often presents not with classic left heart failure, but with septic pulmonary emboli. Pieces of the infected vegetation break off, travel to the lungs, and cause pneumonia-like symptoms, fever, cough, chest pain, and characteristic lung nodules on X-ray. An exam question describing an intravenous drug user with fever and multiple lung cavities should make you think to tricuspid endocarditis. Actually, in your future clinical practice, if you see a remark, unexplicable, long-lasting pneumonia, very difficult to treat with classic antibiotics, ask this guy about intravenous drugs. If he or she could answer. Yes, it's a huge challenge, my beloveds, unfortunately. God forbid. Next, if patient is diagnosed with endocarditis caused by the bacterium Streptococcus gallolyticus, formerly actually known as a Streptococcus bovis. In my time it was Streptococcus bovis. Why they changed it, no idea. Actually, anyway, so if a patient is diagnosed with endocarditis caused by this bacterium Streptococcus gallolyticus, no ancient Streptococcus bovis, it's a massive red flag for underlying colon cancer or polyp. So this bacterium normally lives Where? In the gut. And the breach in the colon's mucosal barrier, like an ulcerating tumor, allows it to enter the bloodstream. So, exam gold, actually in clinical importance, finding Streptococcus gallolyticus, okay, Streptococcus bovis, the same, in the blood is not the end of the workup, it's just the beginning. So the rule is simple and absolute. Streptococcus gallolyticus bacteremia equal mandatory colonoscopy. So this is a classic. What is the most appropriate next step in management question? Remember that. Don't shame my name. Next, the diagnosis of endocarditis is rarely made with a single test. So it requires assembling clues like a detective. So the Duke criteria, Duke it's a name, the Duke criteria provide the formal framework for this combining so-called major criteria: positive blood cultures for a typical organism, evidence of endocardial involvement on echocardiogram, and so-called minor criteria, for example, fever, predisposing heart condition. What else? Vascular pneumonia. Vascular phenomena, immunological phenomena. So minor criteria are fever, predisposing heart condition, vascular and immunologic phenomenon. Okay, phenomena. And major criteria, positive blood cultures for a typical organism, evidence of endocardial involvement on echo. Is that clear? Great. So, exam gold. If you don't need to memorize every minor criteria, but you must understand the concept. A definitive diagnostic requires 2 major criteria, or not. So if you've got 2 major, of course, no doubt, but or 1 minor or 1 major plus 3 minor, or no, so it depends, 5 minor criteria. It teaches you to build a case for the diagnosis systematically, my beloveds. Okay. Now about revealing, So a single, we understand that. So a single positive blood culture is not enough. The standard protocol for suspected endocarditis is to draw 3 separate sets of blood culture, but from different venipuncture sites over a period of time before starting antibiotics, not classically. So 3 separate sets of blood culture from different points, different sites. No, venipuncture, of course. So this practice is crucial for 2 reasons, and you will be asked about that. First, it maximizes the chance of capturing the causative organism, as the bacteremia can be intermittent. Second, and more frequently, and more importantly, not frequently, finding the same organism in multiple cultures. So it's like detective, I repeat, finding the same organism in multiple and different cultures drawn from different sites, provided it's a true persistent bacteremia and not just a skin contamination from a single bed draw. Okay? Remember that, very interesting point. About echo dilemma. There are 2 main types of echocardiograms used to look for vegetations. Classic transthoracic one. It's a non-invasive ultrasound done on the chest wall, very cheapy, no problem, etc., etc. And transesophageal echocardiogram, TEE, not T, but TEE. So is more invasive, involving a probe passed down the esophagus to get a clear picture from behind the heart. So the real importance of that clinical issue, and actually in gold and exam gold. So the rule is start with a classic transthoracic echo. It's fast and very easy. However, if classic echocardiogram, transthoracic one, is negative or equivocal, but your clinical suspicion for endocarditis remains high, you must proceed to transesophageal echocardiogram. So this test is far more sensitive, no doubt, especially for small vegetations, prosthetic valve infections, and complications like abscesses. Like abscesses, yeah. Okay? Many of the classic named signs of endocarditis are not caused by bacteria directly, but the body's own immune responses, autoimmune reaction. They are manifestations of immune complex deposition and vasculitis. So you must know 3, for examples, the most common ones. Osler's nodules, Osler, that's a name. Osler's nodes, painful, violaceous, nodules on the fingers and toes. So mnemonic O for ouch. Those are immune complex deposits. Rot spots, another name, rot spots, retinal hemorrhage with pale centers. Retinal hemorrhages with pale centers. Also immune complexes, like Osler's. And Janeway lesions. Janeway, another name. So non-painful erythematosus macules on the palps and soles. These are different. They are caused by septicomicroemboli, not immune complexes. Pediatrics know this phenomenon very well. So sepsis, nor sepsis, or non-sepsis. So presence of non-painful erythematosus macules on the palps and soles, they are different. They are caused by septic microemboli, not immune complexes. And sepsis, highly likely. Now about HACEK or HACEK, this abbreviation, HACEK Group. Sometimes the patient has all the signs of endocarditis, but their blood cultures are negative. One classic cause is infection with a group of slow-growing gram-negative bacteria known as the HACEK organisms. So what is this hash? Haemophilus. A. Aggregatibacter. C. Cardiobacterium. E. Eikenella. K. Grek. Kingella. Okay? So these organisms require special culture conditions and prolonged incubation to grow. They are a classic cause of so-called culture negative endocarditis. If an exam question describes a patient with a few murmur and fever but negative blood cultures, you should immediately consider HACEK groups or other fastidious organisms like Coxiella and Bartonella. This is all concerning HACEK, I suppose. I think it's largely sufficient. So another point, when to call surgeon, cardiosurgery. Even the right antibiotics, some patients will need urgent open heart surgery. The decision to call the surgeon, no cardiosurgeon of course, is one of the most critical in managing endocarditis. So the major indications for surgery are easy to remember with mnemonic CHF, like congestive heart failure. CHF. What is this C? C is for congestive heart failure. Of course, this is number one indication because it means if the infection has destroyed a valve and the patient is in heart failure, they need a new valve, and it's quickly because it's a catastrophe. So first, congestive heart failure. HASH, heart block or abscess. The infection has spread beyond the valve into the heart's conduction system or formed a pocket of pus, abscess. F, fungal or resistant organisms. Infections with fungi or highly resistant bacteria are very difficult to clear with medicine alone. I can say it's impossible. And E, emboli. The patient continues to throw septic emboli to the brain or other organs despite so-called appropriate antibiotic therapy. Why so-called? Appropriate antibiotic therapy. And about prophylaxis, actually paradox, prophylaxis paradox. For decades, and I remember that, it was thought that many people with minor heart conditions needed antibiotics before dental procedures to prevent endocarditis. The guidelines have drastically changed. It was found that the risk of routine daily activities, like brushing your teeth, causing bacteremia is far greater than a single dental procedure. Of course, if stomatologists do all sepsis and antisepsis, septics and antiseptics, of course, if it's a normal stomatologist and dentist. God bless them. And the widespread use of antibiotics was causing more harm, resistance, side effects than good. Okay? So what's importance of that? So today antibiotic prophylaxis is only recommended for a very, very small group of higher risk patients. This includes those with prosthetic heart valves, no doubts. We have to, as a prophylaxis, give antibiotics. A previous history of endocarditis? Yes, as well. But next, very interesting point. Certain complex congenital heart diseases. Yes. A heart transplanted with valvulopathy, but with heart valvulopathy. Anyway, this is an absolute indications. But a patient with a small mitral valve prolapse or bicuspid aortic valve no longer needs prophylaxis, means antibiotics. Okay? So bicuspid aortic valve and mitral valve prolapse, no more indications for antibiotics. No, before surgical procedure, I suppose. So that's all. Thanks God, my friends. I clarified all these several points on your previous big board exams. I suppose everything's clear. God bless you. Don't forget to follow and subscribe my Dr. Y YouTube channel as well as my Dr. Y Telegram channel. I suppose my Telegram channel is more interesting than this one. So how to find my Dr. Y? The same name, Dr. Y, W-H-Y. W-H-Y without question mark. So you type in searching mode in Telegram, Dr. Y, you click start, you choose your plan, and I will see everything in my channel, on my private channel Telegram. Stay blessed. That's all, folks.